will join. Welcome to the second Pan North East London CKD education webinar. It's a great pleasure to be here. I'm Gavin Dreyer, consultant nephrologist from Whipps Cross. I'm the clinical lead for the Barts Health Virtual CKD programme. I can see lots of familiar faces and familiar names. Before we get cracking in the time-honoured tradition, just a little bit of housekeeping. If I can please ask everyone to keep yourselves on mute if you are not talking. Use the hands up function if you want to raise a point, and we'll keep the chat open for questions as we go along. Thanks, Joanna, also for arranging us, marshalling us all together, sending out the invites. We've got two fantastic talks, and I would say that because I'm giving one of the talks about two really, really important aspects of chronic kidney disease, its treatment and its management. And I'll get on and introduce those talks in just a second. We've got an hour together. There'll be lots of time for Q&A, but I just first of all want to start by giving you a bit of an update about the overall picture with the Barts Health Virtual CKD service, which is really pretty fundamental to what we do and how we manage CKD jointly between primary and secondary care. So I've got a few slides on that, then we'll hand over to Kieran, and then I'll talk about the second half of the meeting. So just a quick refresher. I know I showed these slides at the last webinar. I'm going to show them again because they remain relevant and up to date. It's about how to refer into the virtual CKD service. For colleagues in City and Hackney, Waltham Forest, Tower Hamlets and Newham, this should be old hat, but it's always worth a reminder, and I'll tell you why in a second. For colleagues joining from BHR, we are really actively pursuing the launch of the virtual CKD service in BHR. I don't want to give you a timeline, but we're hoping it's going to be soon within the next few months, and a huge amount of effort is being put into making that a reality. In terms of referring into the service, the key point I'm going to make is that this is a truly virtual service. At no point when we deliver our virtual CKD reviews do we contact, speak to, or require the patients to make contact with us. And I say that because despite our best efforts, we've tried to suppress letters going out to patients to make sure they don't inadvertently come to hospital, because for technical reasons, our clinics are actually hosted on a Sunday morning. A couple of weeks ago, a patient didn't quite understand the information and actually turned up on a Sunday morning expecting a face-to-face kidney review, which is really uncomfortable for the patient and their relatives. So please, when you refer to the virtual CKD, if you could remind your teams and your patients and their relatives, it's a truly virtual experience with no contemporaneous patient contact. Please also don't give the patients any appointment details, because we won't be there to see them because they are hosted in our computer systems on a Sunday. And just a reminder also that the virtual CKD service is for patients with chronic kidney disease who are not known to any other part of the renal service, including but not limited to our general nephrology clinics. This is for those patients who've predominantly been managed by primary care, but for whom advice is required. If you've got a transplant patient, dialysis patient, lupus, vasculitis, general nephrology patient, they will all have a named consultant who you should reach out to directly. All CKD referrals should really come to the virtual CKD service, and I'll put some slides in the chat about this later, or send them around. Perhaps, Joanna, you could circulate them. We're asking everybody not to use a standard advice and guidance portal, because they'll be redirected to the virtual CKD service. That's one exception is for the System 1 practices in Waltham Forest, and that'll be the same case for the very few System 1 practices in BHR where advice and guidance is still open. And it's a reminder that this is a service which is for patients with stable CKD. This is not the right place to refer for an acute kidney injury, hyperkalemia, nephrotic syndrome. The on-call renal team at the Royal London is well placed to handle that. If you'd like to get hold of us, here are our details. Again, these slides will come round. Hopefully you've all seen them before. Just going to stop sharing. I'm going to pause briefly and just see if anybody's got any quick comments, questions or points before we get into our first speaker today. Okay, I can't see any hands up, so it gives me very great pleasure to introduce our first speaker, Dr. Kieran McCafferty, consultant nephrologist at the Royal London Hospital. Kieran is a national leading light in chronic kidney disease, its diagnosis, prevention, its treatment, and has very kindly come to give us some time today to talk about really important aspects of improving outcomes of chronic kidney disease, a particular focus on coding. But Kieran, talk us through how we can work together to make lives better for our patients with CKD. Well, there'll be some time for questions afterwards, but again, hands up or messages in the chat. And thanks about the, I do talk too fast, sorry about that. Kieran, thank you.
Lovely, thanks Gav. Hi everybody, can you hear me? I presume yes, and you can see my slides. Great.
Yeah, we can.
So Hi everybody, my name's Kieran McCafferty. I'm interested in diabetic kidney disease. So over the next 20 minutes or so, I'm going to tell you probably stuff you know already about why CKD is bad for patients and why it's expensive, and then what we can do about it. So the reason why we are all worried about CKD, or the reason why a lot of us, are, it's not that patients end up on dialysis. They die of cardiovascular disease long before they end up on dialysis. We know that CKD is associated with a hugely increased risk of all forms of cardiovascular disease. If someone with CKD stage 4, so a GFR 30, is more likely to die of cardiovascular disease than they are to end up on dialysis. So as a kidney doctor, we are all about cardiovascular reduction doctors. The really important thing is we often think it's about the GFR that's the main driver of this increased risk of cardiovascular disease, but actually if it's proteinuria, and if you would take away one thing from today, it's the centrality of proteinuria identification, management, reduction to improve the quality of lives for our patients. So this is a kind of graph that shows how proteinuria and GFR interact. So this looks at cardiovascular death, and if you can see on the right it says GFR, so GFR more than 90, 60 to 90, less than 60, and you can see how as your GFR falls, your risk of cardiovascular death goes from 1 to 1.9. If you look at those people with who have a GFR more than 90 and they've got no proteinuria, microalbuminuria, macroalbuminuria, the risk of death is higher, such that in those people with macroalbuminuria, there's almost 3 times the risk of death. Compare that to someone with a GFR less than 60, only 2. But when you combine increasing proteinuria and reduction in GFR, that's when you see the summative disadvantages, the summative outcomes of cardiovascular death at the very back in the grey, 6 times the risk of cardiovascular death. So what we're really interested in is how do we detect, manage proteinuria in our patients. We are very good at doing blood tests. So this is looking at older audit data in diabetes, high blood pressure, and other risk factors. Overall, primary care is excellent at doing yearly blood tests for people at risk of CKD. However, looking at urine tests, we are very, very bad at doing it. So even people with diabetes, and this was pre-COVID, just over 50% of people had their urine tested every year. So that's a huge swathe of people who didn't have the urine tested, and so we can't identify whether or not they've got chronic kidney disease. In those people with high blood pressure, it's even less. It's a quarter, or just over a quarter of patients have their urine tested. 3/4 don't. And then other risk factors, family history, established cardiovascular disease, which is in line with NICE guidance. So NICE guidance tells us we should be testing for proteinuria or albuminuria in this group of people. We are very, very bad at doing that. So that's the main thing we need to do is try and get better at doing proteinuria testing. Why are we so interested in trying to prevent people ending up on dialysis? Well, dialysis is miserable and it reduces quality of life and people die, but it also is incredibly expensive. So this is data, again, older data, but it just shows you the split of money sent to look after patients with kidney disease. And we spend 1/3 as much on just dialysis transport, so just getting people up and down to dialysis via buses, as the entire primary care budget for tests and consultations. And that's such a huge disparity in focus for the cost of looking after people. And if we can move, renal replacement therapy is a tiny, tiny percentage in number of patients who've got chronic kidney disease, and yet we spend half our budget on them. And if you only try and move some of that budget from end-stage renal failure care to primary care, earlier stage, to try and prevent people ending up on dialysis, I think it'd be a very, very good use of money. One other thing is we need to tell people that they've got chronic kidney disease. So we are very, very bad at telling patients they've got chronic kidney disease. This is American data, but it's very similar in the UK. And looks at people, depending on what CKD stage they have, 3A, 3B, 4, are the patients aware that they've got CKD? So if you look at people with CKD 3, only 9 out of 10 people don't even know they've got CKD. If they've got CKD stage 3B, it goes up to just sort of 1 in 3 people don't know they've got CKD. And in CKD stage 4, we've still got 40% of people not knowing they're chronic kidney disease. So what are we going to do about it? It's about early identification, coding, and optimizing care. So the LKN has set up a pathway that identifies people who are at risk of CKD. And this is all in line with NICE guidance. It's called a kidney health check. There's no rocket science about it. It's just doing an EGFR and a UACR test. Who should have it done? Anyone with diabetes every year, and anyone with high blood pressure. Sorry, could you put yourself on mute, please?
Sorry, can you please mute, please?
Thank you so much.
Thank you. So it should be anyone with diabetes every year, as we know. and anyone with high blood pressure should have a proteinuria check every 1 to 2 to 3, maybe up to 4 years. But if they've got poorly controlled hypertension, we should probably be doing it more frequently than that. Similarly, anyone with established cardiovascular disease, we should probably be checking for proteinuria. We do UACR. If they've got no proteinuria, great. We check their GFR to make sure they don't have a reduction in their GFR. If they've got raised GFR, according to NICE guidance, if they've got a UACR more than 70, they have chronic kidney disease. If it's between 3 and 70, we need to reconfirm to make sure it's not a temporary phenomenon. And then we check their GFR to establish whether or not they've got chronic kidney disease. If they've got a GFR less than 60 or persistent proteinuria, they've got chronic kidney disease. We tell the patients they've got chronic kidney disease, and we code them for CKD, which we'll come on to in a bit. We do all things that primary care do so well already: lifestyle modification, diet, exercise, giving up smoking, all the kind of the stuff which is so important. And then look at how we can manage these patients with chronic kidney disease to reduce the chances of progressing towards end-stage renal failure or an earlier cardiovascular death. In terms of coding, we're producing coding guidelines, but essentially what the LKN is saying is we should be coding CKD according to what NICE says is a G staging and an A staging. So G based on GFR and A based on albuminuria, rather than saying, coding for CKD or patient has chronic kidney disease or chronic renal failure. We should be using the coding nomenclature. This is based on the KDOQI heat map. And really what it says is that the CKD staging is CKD G3AA2, which sounds like a mouthful, but it tells you an awful lot about the patient and the patient's risk of renal progression. It's based on their GFR, so G1 is greater than 90, G2 is 60 to 89, G3 is 45 to 59, etc., etc. And the A staging is A1 is normal to mildly increased, so less than 3 milligrams per millimole. A2 is 3 to 29, and A3 is more than 30. And together with these 2 points, you can look and see what the risk of end-stage renal failure is. And the updated guidelines are not just the risk, but what we should be doing, treating or referring. And so we should be encouraged primary care to treat these patients who've got, G1 to G3B with little proteinuria. But as the proteinuria rises, we should be referring just to make sure there's nothing else going on in their kidneys. What is the benefit of coding? Well, those people who are coded live longer. And we're not saying that coding is in some way an inherently therapeutic strategy, but it links with overall good care. So here you have people who, compared to those people who are coded for CKD, those who are uncoded for CKD have 500% increase in death with advanced CKD. But even at very much milder form CKD, there's an increased risk of death associated with those who are uncoded. Why is that? Well, one of the reasons is before people's diagnosis of CKD, their GFR falls more rapidly than after CKD diagnosis. So diagnosing someone with CKD is associated with a stabilization of their GFR. And again, it's not some kind of magic spell that we have over patients. It's just that when we code for CKD, we're more likely to do the things that matter for patients. They're more likely to have their blood pressure checked. They're more likely to have their creatinine checked. They're more likely to have the proteinuria checked. They're more likely to have their HbA1c checked. They're more likely to be on the medicines that matter: ACE inhibitors, ARBs, SGLT2, statins. They're more likely to be on, for diabetes, they're more likely to be on SGLT2 inhibitors and GLP-1 receptor agonists. So coding for CKD is the important step in the journey, telling the patient got CKD and getting them on the medicines that matter. Why is it so important to try and identify people early? Well, because if we wait until people develop significant chronic kidney disease, so if we try and intervene when someone's got a GFR of 30 and saying, let's get them on the medicines that matter, we can buy them maybe 3 years until they develop end-stage renal failure. But if we identify that patient with a GFR of 70, but with proteinuria, getting them on the medicines that matter, we'll come on to that in a little time, we can buy them hugely advanced years before they develop significant CKD, so 11 years. And it might then be that someone who's 70, an extra 11 years gets them to 92, and at that stage we wouldn't dialyze them anyway, so we've prevented someone being on dialysis. So early identification is really key in preventing people ending up on dialysis. We at the LKN have tried to make it easy to manage people, looking particularly people with diabetes and proteinuria kidney disease, so people without diabetes but who've got albuminuria, and we want to ask to do three things within 3 months to save lives. 3 and 3 guidance. So we've asked encouraging, or saying this is what we think looks a good model of care. When you've identified someone with, for example here, diabetes and chronic kidney disease, get them on an ACE inhibitor, get them on the maximum dose ACE inhibitor within a month. So start them on 5 of ramipril or 150 of irbesartan, don't start them with 1.25 of ramipril and slowly up titrate, because each increased step is more work for you in primary care. Start them on a medium dose, check it again in a couple of weeks' time, and increase them up. Month 2, get them on an SGLT2. So as we know, SGLT2s have revolutionized the care for people with diabetic kidney disease. And then month 3, control their blood pressure according to targets. Again, this is all in line with NICE guidance. This slide tells a bit more granular data about how to do it. It also talks about getting people on a statin, counselling people about sick day rules, and really lays out the kind of pathway for this optimization. In those people without type 2 diabetes who are proteinuric, it's exactly the same. So again, month 1, get them on a maximum intensity RAS therapy, so ACE or ARB, don't mind which you choose. Get them on an SGLT2 inhibitor, don't mind which you choose. Currently, the only licensed one for those without diabetes is dapagliflozin, but it is likely that empagliflozin will be licensed in the coming years. And action 3, get their blood pressure well controlled, get them on a statin. So the last 8 years has been revolutionary in the number of trials, the number of new therapies that have been shown to be cardiovascular benefit in people with diabetes and CKD. And so there's been a rapidly moving field, and my heart goes out to primary care because I only look after people with diabetic kidney disease, but obviously you've got to look after all these patients, and it's really, really hard with the rapidly changing guidelines to know what to do. And really, this has been the golden age of new therapies, of SGLT2s for kidney disease. And every month there seems to be a new New England Journal article about a new SGLT2 inhibitor showing beneficial effects in CKD. And I can often feel that actually we've won the war against renal progression. And unlike, or just like George Bush, that's not the case, that we haven't mission accomplished. And the reason for that is if you look back at the ACE inhibitor and ARB studies, losartan and ramipril showed huge benefits and became the cornerstone of management for the last 20 years. But if you actually look at the residual risk, so there's still a huge risk of patients progressing towards end-stage renal failure in the era before SGLT2s. So a relative risk reduction of 16%, that's still left 84% of patients progressing to end-stage renal failure. In the era of SGLT2s, so you compare those people who were on an ACE and ARB, adding in this case, canagliflozin, but other SGLT2s are basically the same in terms of effect size. There's still a 50% risk of renal progression, even despite SGLT2s. So the battle against progressive CKD is very much not one. We need other agents to help us prevent the devastating consequences of CKD. And it's often like we wait 15 years between ACE inhibitors and ARBs until 2015. There are no new therapies for CKD or for proteinuric CKD unless for specific targeted therapies. And then suddenly, like London buses, 6 come along at once: GLP-1 receptor agonists, mineralocorticoid receptor agonists, and GLP-1 receptor agonists. And it can be hard to know which one to do. And it's a complicated and rapidly changing guideline. So it is complicated. This has led to significant changes in international guidance of how we should manage our patients type 2 diabetes or diabetic kidney disease. So certainly lifestyle advice. We should be going in with SGLT2 and metformin as first-line therapy for patients with type 2 diabetes. And if they need an extra anti-diabetic agent, GLP-1 receptor agonist is the next choice rather than anything else. So we should be preferentially choosing GLP-1 receptor agonist, and explain why in a few slides. We should be getting them the maximum tolerated RASI dose, and if they need additional therapy, then we should be going in for non-steroidal mineralocorticoid receptor antagonists. And again, this is a new therapy area which you'll be hearing more about in the coming months and years. And a lot of nephrologists will be asking you to start finerenone for diabetic kidney disease. And I would imagine in 2 or 3 years' time, when we show that this works in non-diabetic kidney disease, it will be in addition to ACE and ARBs for all those people with diabetes and with proteinuric kidney disease. So this is finerenone. So this was published a couple of years ago in the New England Journal of Medicine. So with people with diabetes who are already on ACE inhibitors or ARBs, randomized to finerenone or placebo. And what essentially it showed over 2.5 years was a reduction in renal endpoints. So the people who were on finerenone ended up having less kidney failure, less falling in GFR, and less death from renal disease, and also less MACE, so less cardiovascular death, less non-fatal MI, less non-fatal stroke or hospitalization for heart failure. And taken together, this has led NICE to approve finerenone for people with diabetic kidney disease with a GFR between 25 and 60 who are proteinuric. Currently in East London, it's amber on AMARC, so it'll really be nephrologists will be suggesting to primary care to initiate finerenone, and it's very similar to spironolactone, but probably less chance of putting your potassium up. Although there is a small risk of hyperkalemia, so we ask people to check the potassium again 3 to 5 weeks after starting it to make sure they're not hyperkalemic. What else can we suggest? I just wanted to emphasize GLP-1 receptor agonists. Often we think about diabetic kidney disease after metformin, after SGLT2, adding in a DPP-4 inhibitor because they're safe and they're easy and they're well tolerated. But are we doing the best for our patients? Well, for patients with diabetic kidney disease or patients who are obese without diabetic kidney disease, it's clear that GLP-1 receptor agonists are better for patients than DPP-4 inhibitors. The reason is that they, as well as controlling blood sugars, they do other things. So this is multiple studies looking at different GLP-1 receptor agonists, semaglutide, liraglutide, exenatide, etc. And they have all got beneficial effects on composite kidney income, specifically around proteinuria reduction. And as kidney doctors, we're obsessed about trying to get people's proteinuria to fall. We also know that losing weight is beneficial in many other effects. They also are broadly improve people's MACE, so improve hospitalization, heart failure, death, etc. Unlike DPP-4 inhibitors, DPP-4 inhibitors are safe, but they don't improvements in renal or cardiac outcomes. So we should be really looking towards, when patients with diabetic kidney disease, how do we reduce the chances of them developing complications? And so I totally agree with international guidance, metformin, SGLT2, and then GLP-1 receptor agonists if you can get them, because I know that they're very scarce. I hope I left time for questions. I'm going to end my slides. Happy to take your questions.
Kieran, thank you very much. Thanks. Colleagues, there's a number, maybe we should just go to the chat, Kieran, if that's all right, and then whilst colleagues think of anything. So there's a point there just about communication about the coding. What would you say about how we sort of interact in terms of primary, secondary care about the coding? I see it predominantly as something that is work that needs to sort of be undertaken predominantly in primary care. Is that a fair assertion?
Yes, so CKD coding should be it's a primary care. I think we as nephrologists should be doing it as well, but it's that most people with CKD are in primary care.
Great. Colleagues, hands up or notes in the chat, please. We'll go through them. Now, Kieran, a question about AKI and canagliflozin and a dose reduction. How would you address that?
So first of all, what I'd say is SGLT2s do not lead to acute kidney injury compared to placebo. Indeed, in the trials across all the agents, there's a less risk of AKI with canagliflozin than placebo. That being said, if someone does get AKI, for example, they fall over, get run over, they have a heart attack, they have a massive GI bleed, then it would seem reasonable to stop their SGLT2s, a bit like metformin or their ACE inhibitors for a few days until they're better. But it's really important that to get the message out there that SGLT2s are not associated with AKI and that they drop the GFR transiently, but that can recover after stopping it. And so I wouldn't recommend testing the GFR after starting an SGLT2. Start an SGLT2, fire and forget. I agree that the fact that GLP-1s are a challenge that should be resolved next year. There was as early as possible get close to GFR in primary care. So in terms of ACRBs, SGLTs making things worse, so we know from Stop ACE, so a study that looked at whether or not we should stop ACE or ARBs with GFRs less than 25 didn't make any difference to dialysis incidence or hyperkalemia admissions. So there's evidence that with very advanced CKD, ACE inhibitors, if they're on them, I wouldn't necessarily stop them if they're getting on well with them. I wouldn't necessarily start an ACE inhibitor with a GFR around the low 20s, just because it may make things worse and it may mean that they have to come up and see and have dialysis discussions. But there's certainly for SGLT2s, I wouldn't start SGLT2s below 20, maybe below 25. Safe, but there's very little data of starting them will lead to the outcomes, but it's very, very safe. So I wouldn't worry about safety. It's just it may not be as good value for money. Linagliptin is suitable to CKD. Linagliptin is suitable, but are we doing the best for our patients? What our patients need? Our patients need not to die of cardiovascular disease. Linagliptin does not alter cardiovascular rates. Linagliptin is good, and I don't mean to be an anti-linagliptin. It's good at making the HbA1c better, which is really good. They're very well tolerated, which is really good. But in my opinion, I want to try and get towards how do we reduce the complications of diabetes, that is heart disease, eye disease, stroke, and kidney disease. And so I would argue that GLP-1, if we could get them, are better at doing that than DPP-4 inhibitors. So yeah, it does require training, but for injectables, agreed. So does insulin, and we use a lot of insulin in primary care. So I agree that GLP-1 receptor agonists do need a bit of training, but it's a once-a-week injection. And so I would hope that when you talk to patients, it says, look, with GLP-1 receptor agonists on the whole, particularly those who are obese, you can lose 15% of your body weight. That normally goes down well with our patients. If a patient is hypotension with SGLT2 and RAS, do you stop the SGLT2? I would stop the RAS inhibitor first, because we know that RAS therapy is more, you'll get more of your blood pressure back with stopping your ACE or ARB than your SGLT2. So I would stop the ACE inhibitor, but continue on the SGLT2. With statins, I wouldn't. So I would just put them on a statin and not really check. I wouldn't necessarily check to see the cholesterol again. I would just do it routinely, maybe at their next yearly appointment. The guidance for statins is not in CKD is not really based on an absolute cholesterol level. Get them on a high dose statin, and if you could try and mute, please. Get them on a high dose statin. And forget about it, unless they've got a particular other secondary need for intensively managed cholesterol, post-MI, post-stroke, etc.
Kieran, there was a question there just about how to actually enter a CKD code on EMIS. Now, your coding guidelines have got a whole list of codes. Should we send them round? And then I think that should answer that particular question. We can sort of send your coding document round. Fantastic. Yep. Kieran, thanks. I've got there may be a couple more points, but I just want to come back to an issue about coding. I've done some CKD registry reviews with colleagues in City and Hackney. And when we talk about coding, the question I'm consistently asked is about an elderly patient, 85, 90 years old, who've got a GFR of 55 and no proteinuria. Gavin, should I code this patient with CKD? My view is yes, and I'll explain my rationale. What's your view on this?
Yes, you should, and because they've got CKD, and so I think that we having CKD in the era of, we've got lots of therapies that we can alter their outcomes. I mean, obviously, if you're 90, you may be having a more pragmatic approach, but there's no disadvantage to coding for CKD in these people. You're more likely to trigger to remember to manage their other risk factors or control their blood pressure. Remembering that all these blood pressure targets are, for the average patient. If someone's incredibly frail and you're worried about them falling over, you may choose to manage their blood pressure a little bit less zealously than those younger people. But there's no reason why not you shouldn't code for CKD.
Great. Kieran, one more question out of left field. You talked about the importance of testing proteinuria, and I was asked, for patients who do night shift work, when should they collect the urine sample?
It doesn't matter. So I also want to get away with the idea that early morning urine is important, because just getting any urine is important. The early morning urines are a little bit better than any other time, but the reason why urine ACR is so good is it corrects for the changes in your overall urine concentration. So what I would say to patients, look, if you can get a first morning urine, fine. If you can't, don't worry about it. Just bring it into the surgery, because it's more important to get the urine tested at any time than to get the best possible test. If someone's in night shift, do it whenever you want to bring it in.
Yeah, thanks. I think we've been wedded to this idea of early morning urine samples, and that's made life just a little bit more difficult than necessary. Colleagues, any last questions, comments, or points for Kieran? We'll send round. Kieran, is it all right? Could we share your slides from the talk? I think it'd be a couple of requests. We'll share the London Kidney Network CKD coding guidelines. It doesn't look like there's much more coming in, so that was absolutely fantastic. Thank you very much indeed. Are you hanging around, Kieran, or are you disappearing?
Yes, just one more question. With just GFR, and especially they're working on protein shakes. Well, what I would say is, if someone's young and it's got a reduction in their GFR, that's important to know, because their lifetime risk of CKD is very, very high. And so what I would say is, I would not encourage protein shakes with anyone with significant CKD, because we want to try and have a normal protein intake, so less than 1 gram per kilogram per day. If you wanted to, you could do, if they were very, very muscly and were very working out, you might want to do a different way of testing their kidney function to ensure that they didn't have underlying CKD. So you could do a measured eGFR. But having someone with young people with CKD, that would be someone also that you could refer to CKD, because we're always keen to see young people who there's a concern about, because they're the people we can make a difference in 10 years down the line.
Right,
the urine ACR shouldn't matter.
Yeah.
Two is, yes, you should start them. They have diabetic kidney disease, and you should start them on an metformin and an SGLT2 within, metformin 2 weeks later, SGLT2. Don't check the bloods again. Yearly yearly kidney health check, and refer on as necessary.
Fantastic. And that's a great way to segue into the next talk, which is me talking about the kidney failure risk equation. Kieran, thank you very much once again. Colleagues, I'm going to share try and share my slides. Hopefully you can all see this, and it should be in glorious Technicolor and full screen, but shout if you can't. This is a discussion about, I guess, the new kid on the block, the new tool for us all to use, the kidney failure risk equation, or the KFRE, which has just been really transformative in how we risk assess and risk manage patients for CKD once they have been diagnosed and coded. I've got some slides here which I'll send round. They are. Oh, sorry. Sorry, could we all mute if that's all right? Sorry, could we all mute? I hope that's okay. All right, back to sharing. So the kidney failure risk equation, what is it and why are we going to use it?
Oh, they're always.
Yeah, sorry, there's a little bit of background noise, colleagues. If I could ask you all to please make sure you're on mute Thanks very much. Thanks, everyone. Right, kidney failure risk equation. What is it and why do we care, and how is it going to impact on the management of CKD in primary care? Kidney failure risk equation is a really fantastic validated risk prediction tool for the need for either dialysis or a kidney transplant at either 2 or 5 years in patients with chronic kidney disease. This is a tool which predicts the likelihood of anybody needing renal replacement therapy if they've got an EGFR less than 60. To give you some degree of context, I guess it's a bit like the Q risk equation for cardiovascular disease. We use 4 parameters to calculate the kidney failure risk for any given patient: their age, their sex, the EGFR using the CKD epi equation, and the urine albumin creatinine ratio. There it is again, the fundamental aspect of kidney care. Those 4 variables will allow you to predict the risk of end-stage renal failure requiring renal replacement therapy. This is a real game changer for us. And it's been around for a while. It was developed in Canada in 2011. It's been validated over the world, including in the UK. I'm not going to dwell on all of this. You'll get the slides and all the references are there. But the point I want to make now is that NICE have recommended the use of the 5-year risk of kidney failure rather than a GFR or stage-based referral criteria. Historically, you were invited to refer if the GFR was less than 30 or there was a drop in GFR of a certain amount. Now, we've switched that to a risk-based equation. So a kidney failure risk of greater than 5% at 5 years should merit consideration for referral to nephrology services. And I'll talk you through some of that just now. Here's a website. Now, the problem with the kidney failure risk equation is right now it is not yet embedded into our laboratory management systems, either Cerner at Barts Health or in EMIS, but it is coming. And Kieran hosted a fantastic webinar earlier this week, which showed some great examples of deployment of the kidney failure risk equation, I think in the northwest of England, where this has gone live in laboratory management systems, and it's embedded there as part of the routine blood work and the blood results that come through. So this is likely to be a part of our lives moving forward. I'm part of the national group, which is trying to roll this out. So it's coming. Of course, there's a US version of this and there's a UK version of this. We got to use the UK version. The website address is there in a minute. When I've done these slides, I'm going to jump onto the Kidney Failure UK website. We'll go through it and do some worked examples. Right. So when should you use the kidney failure risk equation? Here's a really important point, is that this is for patients who've got CKD stage 3A or worse, 3A, 3B, 4 or 5, and EGFR of less than 60 mils per minute. You can actually sneak in a GFR above 60, but don't, because it is not validated in this group of populations. And the advice currently is to recalculate the risk when the EGFR and ACR are remeasured. Kieran talked very elegantly about the critically important need to reduce albuminuria with the therapeutic options he described, and you can see the change in risk when that is done. And here's a table which outlines the frequency, according to NICE, about recommendations for measurement of kidney parameters based on stage of CKD. Worst stage of CKD, worst proteinuria, suggests increased frequency of monitoring, and that allows you to recalculate risk. When to be cautious, caveats. So this is a tool for patients in a steady state. It's not a tool for patients with acute kidney injury. It's not a tool for patients who have got fluctuating EGFRs. And there's some caveats there about sustained decreases in GFR, about changes in GFR. There's something else there about the validity of the kidney failure risk equation, which also relates to the validity of the EGFR. That's extremes of weight, muscle mass, amputations, and liver failure. And there's been separate talks and guidance about this. The ACR, interpret with caution in urinary tract infection and catheterization. And there are specific kidney conditions, particularly IgA nephropathy, which are much better served by a predictive tool for that particular condition. But as it stands, and given that diabetes remains the most common form of CKD in this country and globally, kidney failure risk equation is a powerful and important tool which will transform the way we look after vast swathes of our population. So once you get the result, what could you say? And there's a package here from NICE about shared decision making, about discussing risk with patients, and discussing risk in the context of each person's life. And this is a point I'll make again, that the kidney failure risk is valid, but it's much more valid as seen through the lens of the primary care team who know the patient and understand the wider perspective. There's some phrases here, some phraseology about how to sort of interpret numbers and percentages, which I feel like I'm teaching you to psychiatrists reading this page. Apologies about this, but these are pre-prepared slides. So there's some advice here which I'll send around. But as Kieran said, it's really, really important to share with patients that they have CKD, that they have been coded for CKD, and what the risk of CKD looks like. And here's some advice about how to take that forward. So what do you do when you get the result? And I've got a couple of slides about this. I've talked to you about the critical importance of sharing this result with their patient and their family members. The advice was to refer with a kidney failure risk of 5% or more at 5 years. But actually, I think a little bit of context is required in terms of patient wishes, their comorbidity, their physical status. Is it necessary to refer a nursing home resident who's 80 with dementia, who's got a kidney failure risk of 5 years of, say, 10%? The answer is almost certainly not. I'm not sure that's going to change much about my management or the care you would deliver. So that the context and the knowledge of the patient is absolutely vital. However, the advice is to consider, not to refer, but to consider referral to secondary care if the KFRE risk is greater than 5% at 5 years. There are other nice referral criteria. I'm going to show you those on the KFRE website in just a minute. And KFRE calculation during annual checkups. Kieran talked about annual kidney health checkups. KFRE really, I think, is going to be a big part of that. But consider other comorbidities such as hypertension, diabetes, and those with more advanced stages of CKD needing more frequent reassessments of risk. Quick summary before I've got a couple of more personalised slides. This is a validated risk prediction tool recommended by NICE, valid if your patient's GFR is less than 60. 4 variables are needed, and we'll talk about how contemporaneous those variables need to be, because not everybody has a simultaneous ACR and GFR. Not suitable for rapidly changing situations, not to be used in acute kidney injury. There's a huge value in discussion and sharing information with patients about their risk and what this all means, and that consideration of referral to secondary care to the virtual CKD service when the risk is greater than 5%, replacing the stage-based referral criteria. So look, let me personalize this, colleagues, and tell you a little bit about how I use the kidney failure risk equation tool, because I do use it. And I do the virtual CKD reviews from City and Hackney, and I more often than not will find myself calculating a kidney failure risk equation to share with you in the notes. It is frustrating that this is not yet available in EMIS or in our laboratory systems locally. It does require you, when you're sitting consulting with the patient or going through a list of notes, to sort of jump out onto a website, punch in the details. It's not automatically pulled data, but I use this to share my thoughts about risk and relative risk in terms of progression of CKD or likelihood of end-stage renal failure. And it's great then that I can share with you advice about therapeutics, what referrals I may make or you may need to make. When I sit and do my general nephrology clinic, I will almost always calculate this risk for patients and give them a much more insightful discussion about their likely future risk, rather than simply telling them what stage of CKD they have or roughly what sort of percentage of kidney function they have and all the other terms I've used to use. I have flipped my conversation with patients quite radically based on this, and I think it makes me a better communicator. I think that staging is helpful, GFR is helpful, but when I start to talk about long-term risk, particularly when that is reassuring, and it sometimes can be reassuring in patients who've got a low GFR but without much proteinuria, I'll show you some examples, then that can really help me just reduce anxiety. How then could primary care teams use this or deploy this? Again, this comes down to what we discussed before, risk stratification. And there's something here about the burden of CKD we're facing, which I don't need to tell you in any detail because you live and breathe it in a way that Kieran and I don't. We've had discussions about who is going to do all this work, who is going to code these patients, who's going to look after these patients. I wonder whether there's something about using the kidney failure risk equation to stratify which members of your team are caring for or looking after patients with either high risk or low risk. And that is an open question, open for debate. Happy to discuss that later. There's something here about referral, which you've talked about. It's really important to say that not all patients will need referral. The virtual CKD service, sadly now with the junior doctor and consultant strikes, has accumulated a significant backlog of cases. So we are happy to receive and answer these cases. But if the KFRE helps risk stratify and mitigate referral, then we'd be thoughtful about that. There's perhaps something about how the KFRE fits into the recall and reassessment of patients on your registers, perhaps thinking about recall based on risk as identified by the KFRE. There's something also about planning follow-up and reassessment. And again, that shared vision of communication of risk between primary care teams, secondary care teams, and and patients. I think that's the last slide I've got. I'm going to send all these round. I'm going to pause for thought and reflection, but I am ready to show you the kidney failure risk equation website. I have missed some of the questions. So yes, Shahid, I'm going to show you the online calculator now. You don't need a slide rule. We are slightly ahead of times. Kieran got a hand up and a couple of points to make there.
Yeah, Gav, I was just going to make the point that actually in everywhere, unless you're in City and Hackney, KFRE it can't be used because unfortunately Bart's Health frustratingly still calculates GFR based on MDRD and not CKD epi, which is a disaster. And so strictly speaking, we shouldn't be using KFRE in anywhere but City and Hackney until it's sorted. I'm having a meeting with the biochemists today to get they're using CKD epi everywhere imminently.
Yeah, it's these are thanks. Listen, Kieran, I'm grateful that you sort of taken us on and raised this point. These are tough times. What would you say about the timeline? Go on.
What I will say is that Ruth is hoping to set up an automatic KFRE percentage from UACRs in primary care. So it's going to if a primary care send an UACR, you'll come back with UACR is X, the KFRE equation, the KFRE risk is that. Yeah. So hopefully that will take away some of the burden of this in the coming months.
Yeah, thanks. We look forward to the updates. I think that's really important to know. And it's great to sensitise colleagues whilst we iron out these important points. There's a couple of other points here. So the KFRE doesn't have ethnicity as a parameter, nor does the EGFR. We have removed the ethnicity correction from the EGFR, which means that we will not be seeing any form of correction for that parameter. And therefore, in the kidney failure risk equation, there's been a huge national and global movement to deconstruct the racial aspect of GFR estimation. And there was mounting evidence and concern that the correction of GFR for ethnicity was doing a significant grave clinical disservice to patients with black ethnicity who would automatically have had a rise of 21% in their estimated GFR, and that has been removed. So that's not part of the EGFR or the KFRE. Right. Okay, colleagues, thanks. I'm happy to take any more questions. I'm going to jump into the KFRE website, which I do with trepidation based on what Kieran has just pointed out, but there we go. Let's bring this up now. And I just want to show you it so we can signpost it, be aware of it, and be ready to use it and understand it when it is deployed, because it is coming. First thing to say, it's a very, very, very user-friendly website. I find it really, really great to use. It's not just got the calculator, but it's also got a huge amount of useful information about the EGFR, about CKD, about risk and risk stratification. There's the website, kidneyfailurerisk.co.uk. And if you just scroll down the landing page, there's reminders here helpfully about staging of CKD. There's reminders about the importance of causes, how prevalent diabetes is, particularly in East London, which I don't need to tell you. There's some fantastic video links about different risk levels and what that means. There's some very important epidemiological information here, and there's some useful background information about the genesis of this equation and its validation. And I am going to give you a worked example when I click on this. So Shahid, you said, what would you have to do? You'd have to get your slide rule out. But you've got to have these 4 parameters. And I'm going to give you an example of a 65-year-old man with a GFR of 45. And in fact, I'm going to just change that a little bit. The GFR of 55, if you like, just below that threshold of 60, I'm going to put in the fact that this man's got heavy proteinuria, probably from diabetes, a urine ACR of 200. I strongly suspect this is not unusual in your surgery, certainly not unusual in Kieran's clinics nor mine. I'm going to click submit, and I am going to have a look here what the kidney failure risk equation is telling me about this patient. It's given me a risk of progression to kidney failure requiring dialysis or transplantation at 2 years of 0.5% and at 5 years of 1.9%. Reassuring, but this patient still has hugely significant proteinuria, established CKD, and is absolutely right for the treatments and processes that Kieran clearly outlined. Whilst we're on this part of the website, I am going to just remind you all that these are the current NICE referral criteria. And you can see in bold here, the 5-year predicted risk for the KFRE of greater than 5% is there, but there are others. There are others relating to the value of proteinuria, reductions in GFR, uncontrolled hypertension, rare genetic causes of CKD or suspected renal artery stenosis, which is rare. So there are the referral guidelines, and here is this patient's current estimated risk of kidney failure requiring renal replacement therapy. So let's just play around this a little bit more to get a sense of where it can take us. And I am going to give you a slightly different example of an 83-year-old who is female with a GFR of 17. And I'm going to put in this patient has got no proteinuria, all right, or very little, minimal A3 proteinuria. And you look at the GFR of 17 and you think, well, this is alarming, and it is quite alarming. And then we get these results here. A kidney failure risk, diagnosis requiring kidney failure at 2 years of 2.4%, higher at 5 years at 8.4%, and that may well trigger or make you think of a referral, which would be entirely appropriate if it is in keeping with the background and context of the patient. But that risk, I suspect, would be lower probably than many of us had thought. Let's go on and give you another example of a young patient, 35, male, with a GFR of 48 and a urine ACR of 70. Again, I suspect fairly common. Let's see what the risk looks like here. And you can see here that actually these figures, although not quite crossing a threshold, these figures I consider to be quite significant in a 35-year-old with about a 5% chance of kidney failure requiring dialysis at 5 years. Unclear what the trajectory of this was, unclear what the background is, but that is the sort of captured risk at that moment in time. And that's certainly someone we should really work actively hard to think about the cause of the CKD, the treatment needs for the CKD, and whether referral would be appropriate in this case. I'm almost certain that even at slightly below 5%, that would be a valid choice. So, colleagues, the kidney failure risk equation, it's coming our way. It's a really important game changer. Kieran's going to work hard to get this right in East London. Thank you, Kieran, for taking this on. I've got time for questions, Kieran. I hope you have too. Kieran, do you want to add anything else about the kidney failure risk equation, how that fits into your manifesto?
I just wanted to say that I don't want primary care to go away and think that kidney failure equation is not useful. It's just that technically speaking, the current way our MDRE calculation, it's 1% difference. So I think if you use the current blood tests from Tower Hamlets or wherever or further out, it will be the most you'll say is a tiny difference, but broadly it will give you the right answer. It's just strictly speaking, we should be using a slightly different way of calculating EGFR, but it's literally a difference of 1%.
Yeah. Kieran, I mentioned also, and we can discuss this, and that not everybody has a contemporaneous urine ACR and EGFR. Yeah. They may be several months apart, even a year apart. What's valid in terms of the distance between the two?
So I asked Rupert Majors, he's done a lot of work. He can get back to me. They've set up a KFRE testing in northwest England, and they are running it for primary care bloods, and they're doing it 6 months. They're doing it 6 months. So if you've had and I think we should probably do it 6 months to 12 months. It's better than nothing, and it will help. So I think we'll look back and it'll be triggered by any UACR, and if any UACR is done with a GFR in the last 6 months, it's more likely that if you've got a UACR test and you're more likely to have a GFR more recently than the other way about, than a GFR test looking for a UACR. Yeah. So we're doing it for a UACR sent. Is there GFR in the last 6 months? And we'll calculate it carefully from that.
Great, thanks. There's a little bit of chat here about ethnicity. Have I got my...
Yeah, I've answered it.
Okay, thanks. And then a question about the renal apple tool, the active patient link tool. Is it something different? It is different. So that the renal apple tool, the CKD apple tool, is designed by QMUL Clinical Effectiveness Group, which is sort of an enhanced and replacement for the trigger tool, which looks at patients who had rapidly falling GFR. It's a really fantastic tool run by primary care teams in EMIS to filter out patients who have got CKD, high risk of CKD, progressive CKD. It doesn't incorporate, Kieran, correct me if I'm wrong, it doesn't incorporate the KFRE, does it? You still have to take those parameters out and put them into a website to calculate the KFRE, to sort of put it into the mix of all the other parameters in the apple tool. So it is separate at the moment.
Yeah, and EMIS know that they're working on it in a future update of EMIS, that it's going to be built in, but they haven't done anything about it yet.
Yeah. And Shahid, your point there is that you're right. You can't get a valid kidney failure risk equation if the GFR is greater than 60. It's not validated in those populations at the moment.
And the reason for that is the EGFR is not that accurate in those people over 60 because the error bars are so wide.
Right. Okay. Thanks, everyone. There's a couple of general questions coming in. In black patients with diabetes, I guess needing treatment for hypertension, would you go with calcium channel blocker, RAS inhibitor, combination of both? Kieran, what's your approach there?
I would go with RAS inhibitor, SGLT2, GLP-1 receptor agonist, finerenone, and then control blood pressure.
Okay.
Because it's always important to not be focused on the numbers, but focused downstream of what we're preventing. We're preventing heart attacks and strokes. What are the agents being shown to prevent heart attacks and strokes? It is RAS therapy, MRAs, and SGLT2 inhibitors.
Yeah. Kieran, there was a lot of chat about ACE inhibitors in black populations, which I don't think holds much water. I use ACE inhibitors in black patients all the time, particularly proteinuria. Any comments on that?
Yeah, so it again gets away from the idea of being focused on the blood pressure targets. So I would rather have someone who was on maximum dose RASI, who was proteinuric kidney disease with a blood pressure of 145, than someone who had a blood pressure of 135 not on an ACE inhibitor, because we know that it's the therapies that are and MRAs, it's the therapies make a difference rather than the targets are important. And obviously, if you've got a blood pressure 200 systolic, however you get it better is better. But it's more important to get them on the therapies that are being shown to make a difference rather than being purely numbers focused. Like what we've learned from HbA1cs, we were too focused on the exact HbA1c when actually what we want to be taking a step back in is a personalized approach of HbA1c and getting the HbA1c down with the agents that control and prevent the other complications.
Thanks. There's a question about patient with prostate and calculus problems. I'm not sure I understand that. I don't see how prostate or calculus problems would impact on the GFR. Okay, colleagues, we've got 6 minutes left. We have covered a lot of ground. Thanks very much, Kieran. We'll send your slides round. We'll send the London Kidney Network coding guidance round. We will send round my slides, and I'm going to ask you, if you don't mind, to please fill in this survey. It's really, really, really important we get your feedback, because this will shape the next webinar. The next webinar is likely much more clinically orientated. This is quite sort of operational and systems level, but I really want to drill down into some of the clinical issues about CKD, blood pressure and how to achieve it, cardiovascular risk and how to reduce it, management of anemia, possibly into bone mineral disease. So if you've got suggestions for what you'd like to hear at the next webinar, let us know. Other than that, I think we can return 5 minutes to everybody's life, unless there are any more burning questions. Hopefully no one's got burning dysuria. Otherwise, enjoy your afternoon. Thank you very much for joining. Be well. Thanks a lot. Take care. Bye now.